It's a great pleasure to have Sharon Lewin give today's Wednesday seminar. Professor Sharon Lewin is a clinician and infectious diseases physician, and she's also a phenomenal scientist. Now, she's the inaugural Peter Doherty Institute director, and formerly she was at the Alfred Hospital as the head of infectious diseases out there and also co-centre head at the Burnet Institute. Now, she was pretty tremendous in organising or being the local co-chair of the HIV/AIDS meeting this year, which I think was the biggest conference in Australia. It was the biggest conference in Australia. And her research interest has really been in getting or promoting remission in HIV infection, and her work and all her efforts have been recognised recently by now receiving or being receiving the title as Melburnian of the Year. So congratulations and pleasure to have you here.
Thank you, Mark. Yes, I was very pleased with, of course, very honoured by the title, but most importantly because the prior winners have included Ron Barassi, Jim Steins, Andrew Gaze, and they've largely been sportsmen or big businessmen. So I think it was the first time that award's gone to a clinician scientist. So I think that's good for all of us, I hope. So I'm going to speak to you about a whole range of projects that we're doing around potentially one day finding a cure for HIV. And just to set the scene, we have absolutely outstanding treatments now for HIV infection. On the left is what people used to take in 1996, and as on the right is what your average person with HIV takes in 2014. Combined treatment, antiretroviral therapy or ART, 3 drugs combined in 1 tablet. We now know that life expectancy is in fact normal in people with HIV who start treatment at the right time. Side effects are rare and drug resistance almost never seen. In addition, with a whole range of factors including significant community advocacy, 14 million people on treatment in low and middle-income countries. So an amazing success story, except that treatment is needed lifelong. Added to that, if you treat someone that's positive, you reduce their infectiousness by about 96%. And that data came from a wonderful study hailed as the breakthrough of the year back in 2011, which showed that if you took a discordant couple, one positive, one negative, the positive person received treatment, you reduced infectiousness. So treatment's not only amazing for the person infected, but it also has a huge community impact. And we now often talk about treatment as prevention. So if treatment's that good, why are we even thinking or trying to find a long-term cure for HIV? And first of all, life expectancy is normal for many people who start treatment at the right time, but if you start treatment late, once there's evidence of damage to your CD4 T cells, life expectancy is reduced, and we know there's ongoing morbidity on antiretroviral therapy. People with HIV are at higher risk of cardiovascular disease, malignancy, and a whole range of other chronic illnesses related to low-grade inflammation. For every 1 patient who starts treatment, there is 1 new infection. So just keeping up with the numbers of new infections is a big challenge. And the third thing is that despite the incredible global effort to make treatment accessible to people in low-income countries, it costs a lot of money, and it's funding lifelong antiretroviral therapy and, more importantly, health systems that can keep people in care lifelong, particularly in low and middle income countries, is probably not sustainable. Estimates of about $50 billion to maintain this by 2020. So the capacity to really keep up that level of funding, even with low-cost drugs, is probably not sustainable. And therefore, that's given this great interest recently in trying to find a way that you could safely stop antiretroviral treatment or not commit someone to lifelong treatment. So I'm going to, first of all, just briefly talk about whether this is just a ridiculous dream and whether a cure is or isn't going to be possible from what we know currently. briefly review what those major barriers to cure are so you can understand why we're trying what we're doing. I'll talk a little bit in greater detail about work my own group has done looking at understanding latency, the major barrier to cure, in vitro and the role of specific chemokines. I'm going to review some clinical trials which we've been doing aimed at eliminating latently infected cells, and just talk about more broad current and future challenges in working in this area. So first of all, is a cure for HIV possible? There really is only one person completely cured of HIV, and that's a man by the name of Timothy Brown, initially called the Berlin patient. He was a man with HIV on antiretroviral therapy who received a bone marrow transplantation from a donor who was naturally resistant to HIV. The donor lacked expression of CCR5, carried a mutation called the Delta 32 mutation, present in about 1% of occasions. HIV needs CCR5 to enter a cell. So the recipient, Timothy Brown, got a naturally resistant bone marrow transplantation. His doctor stopped antiretroviral therapy shortly after transplantation, and the virus never reappeared. He's now 6 years post-transplantation, but he remains the only person cured of HIV. It's unclear whether the major reason was this HIV-resistant bone marrow, whether it was graft versus host disease, whether it was related to the irradiation he received. But to date, and this was first reported in 2009, no one has been able to replicate this case. There have been some other reports of potential cure, which we now really think of as remission because it wasn't long-lasting. And these were two patients called the Boston patients who received a bone marrow transplant, but this time from a CCR5 wild-type donor, so a bone marrow that was sensitive or susceptible to HIV infection. These patients received antiretroviral therapy over the time of transplantation and for several years after, and stopped treatment. And there was initial excitement thinking that this transplantation, even from a CCR5 wild-type donor, led to a cure. But in these patients, the virus returned in one patient at 3 months and in one patient at 7 months. Normally, when you take someone off treatment, the virus returns in about 2 to 3 weeks. So this did something. It certainly prolonged the time to rebound and perhaps achieved what I think is probably a more appropriate word than cure, but remission, at least for 3 months and 7 months. Obviously, our long-term goal is lifelong remission, but an advance on what we know happens in the absence of any intervention. I should just say, of course, bone marrow transplantation is absolutely not being investigated as a strategy for cure, but these are sort of instructive examples for us to get a hint of what might be eliminating persistent virus in people on treatment. The other case was that of the Mississippi baby you may have read about. In this situation, the child's mother, who was HIV positive, did not receive any treatment during pregnancy. At birth, the baby was infected. The baby received very early treatment, which probably had an impact. And then the treatment was stopped at about the age of 18 months. And in this case, the child remained in remission, meaning no detectable HIV for 2.5 years. But after 2.5 years, the virus returned. So these 3 cases gave some hope initially that cure was going to be possible in some particular circumstances. The fact that the virus eventually returned in these patients tells us that long-term cure may be very, very difficult, and perhaps a better goal of what we're trying to achieve here is remission, or time off treatment where the virus remains effectively under control. So we've learned that delayed viral rebound is achievable, but at the moment we don't really know the biomarker for HIV remission or how to predict that someone is going to stay able to keep their virus under control off treatment. And this was nicely summarised in a commentary by John Cohen in Science recently, showing that in the red line is the Berlin patient, the only person that stayed off treatment with an undetectable virus. We can normally detect virus down to about 20 copies per mil. virus remains undetectable off treatment. In green is what happens usually when you stop treatment. Virus goes from undetectable, rapidly appears in 2 to 3 weeks. The Boston patients got a bit more time, 2 to 3 months, and the Mississippi baby here in orange about 2.5 years. And the goal of this work is really to see whether we can push that out to 5, 10, 20 or longer years to keep someone in remission off treatment. So, what are the major barriers to cure, and why has this been such a difficult area, or really an area that hasn't really been tackled until the last 5 or so years? So very briefly, the major barriers are latently infected T cells, and I'm going to go into a lot more detail about what latency is. In some patients, residual viral replication or persistent replication of virus in a person on treatment, though we think this is rare. And finally, there are some anatomical reservoirs, such as the brain and the gut, where there are some unique long-lived cells like macrophages and dendritic cells and astrocytes, but they probably don't play a major role. Without a doubt, most people think the major problem is latency. So what do I mean by latency? Well, HIV preferentially infects activated CD4 T cells. Once it infects an activated CD4 T cell, the infected cell produces lots of virions, and that cell, the infected cell, usually dies. However, in some cases, as with all activated memory cells, a cell can survive, revert to become a central memory T cell, and in some cases can carry an integrated provirus. So in a latently infected cell, the virus is integrated in the genome but doesn't complete the virus life cycle, doesn't start undergoing transcription, translation and virus production, and is effectively silenced. And it always occurs in a resting CD4 T cell. And that's commonly referred to as post-activation latency. An activated infected cell that survives somehow, reverts to a resting state and carries an integrated provirus. The other way that latency can be established is through direct infection of a resting T cell, and that's commonly referred to as pre-activation latency. And we actually don't really understand what happens more commonly in vivo. We just know that in vivo, in people on treatment, you can always find occasional resting CD4 T cells that carry an integrated provirus. Those cells are very rare. They occur at about a frequency of about 1 in a million T cells. But this provirus carries infectious virus. And we've been very interested in establishing models that mimic pre-activation latency, and I'm going to talk a little bit more about that later on. So in a person that's on treatment, if you measure virus in plasma, the virus is undetectable, meaning it's less than 50 copies per mil or 20 copies per mil. That's the usual level of sensitivity of our clinical assays. If you use a really sensitive assay, you can actually always find HIV RNA in plasma at very low levels, about 3 to 5 copies per mil. Stays very stable, doesn't develop drug resistance, doesn't show any signs of evolution, a very kind of stable, low-level viremia, which we can measure as plasma RNA. I described to you these long-lived latently infected cells. They're mainly in central memory T cells, but most recently described in transitional memory T cells. They're infrequent, 1 in a million cells. But the most important thing is that integrated provirus actually does contain replication-competent viruses. So retroviruses all have the capacity to integrate into the human genome and persist. Our DNA is littered with endogenous retroviruses, but most of them don't contain what we call replication-competent virus. HIV maintains the capacity to do so. So that any time if there's stimulation of the promoter of the HIV, which is called the long terminal repeat or the LTR, virions can be released into the circulation. If that latently infected T cell becomes activated through a normal immune response, the activated T cell will start pumping out virus. But in a person that's on antiretroviral therapy, that virus can't go on to infect new cells. So this is sort of the steady state of someone on treatment. There's been really nice studies looking at whether the long-term decay of these cells, which you can measure quite easily, either as just DNA or integrated DNA or replication competent virus, remains present, doesn't decay over basically years on treatment. You have low-level viremia, doesn't go up or down, persists for years on treatment. So one of the strategies that we're always, that mainly what people are thinking about is how to eliminate these latently infected T cells that don't present, that don't make virus, that don't present foreign antigen. There's no virus actively replicating, so therefore not susceptible to antiretroviral therapy, which will block steps in the viral life cycle, not susceptible to immune clearance because there's no HIV antigen presented on the surface of the cell. And finally, some really nice data coming out recently showing that there is some low-level homeostatic proliferation, as there is for central memory cells anyway over a lifespan, and we now know that there's homeostatic proliferation of latently infected T cells. So this is a pretty tough problem, and all the efforts are aimed at really trying to block either the establishment of latency or trying to eliminate latently infected T cells. So we've been really interested in understanding how latency is established and also setting up in vitro models of latency. And this has been really important because you can't really study human latently infected cells from HIV-infected patients very efficiently because so few cells carry a latent provirus. As I said, about 1 in a million makes those studies. It's possible, but it's actually very difficult. So if you try and actually infect a purely resting T cell, and this has been known for years, the virus can get in, it undergoes its first step of reverse transcription, but doesn't efficiently integrate. So you can't just directly infect a purely resting CD4 T cell. And so for a long time, people haven't had a great tool to measure latently infected cells in vitro. If you actually infect a cell in the context of an ex vivo tissue block, so these early studies were done in lymph node tissue, you could actually get quite efficient entry and integration into a resting T cell, which was latently infected, not completing the viral life cycle, not expressing viral antigens, not showing any markers of T cell activation. And several years ago, we sort of mimicked this model of a tissue block by looking at a range of chemokines and asked the question whether incubation of resting T cells with chemokines altered the resting T cell to allow entry and integration. And in fact, we showed that this was quite efficient, that if you added chemokines to an in vitro T cell culture, and the chemokines we specifically looked at were chemokines that bind to CCR7, which defines a central memory T cell. So it was CCL19 and 21. And in our initial papers showed that ligands for CCR7 allowed for efficient entry and integration. And then we subsequently demonstrated that actually ligands to multiple chemokine receptors that are all expressed on resting T cells, including CXCR3 and CCR6, all allowed for efficient in vitro infection. What was the chemokine doing? Well, in brief, the chemokine was altering the cytoskeleton or actin cytoskeleton in a resting T cell. This just shows you what happens to actin when you add the chemokine SDF1, the ligand for CXCR4, or CCL19, the ligand for CCR7. You can see changes in the actin cytoskeleton. And when we blocked those changes using jasblakinamide, we could basically inhibit integration in this model. So the chemokines were altering the actin cytoskeleton and allowing for efficient entry of the virus into the nucleus and efficient integration. And then there's subsequently been many different approaches to show how you can condition a resting T cell to allow for integration in an in vitro model, but that's going to give us clues about what's happening in vivo. So we then went on to do a range of studies looking at myeloid DC resting T cell interactions, and that also conditioned efficient entry and integration. And other groups have looked at co-culture of other cells, in this case endothelial cells with resting T cells. And this environment of a resting T cell in a high level of chemokines or close contact with DCs or endothelial cells is really the environment that you obviously see in tissue sites, lymphoid tissue and gastrointestinal tract. And that may well explain why we see a lot more latently infected T cells in tissue sites rather than circulating in blood. And we've recently been looking at this in far greater detail in a collaboration that we have with at UCSF, where we've been recruiting patients that are on treatment. They've had viral load suppressed for a long time, and then interrogating where latently infected T cells sit in blood or lymph node or rectal tissue. And we do this in these series of studies by measuring the amount of integrated HIV DNA we can measure per million cells. And you can see between blood and rectal tissue, there's almost about a log higher frequency of latently infected cells in patients on treatment. We've also been asking whether any of these chemokines or chemokine receptors could be used as a marker for cells that are preferentially infected. We know that latency occurs in central memory and transitional memory T cells, but can we define that better to identify a phenotypic marker that's enriched for long-lived latently infected T cells? And because of the in vitro work that we demonstrate, because of the data we demonstrated from the in vitro model showing importance of chemokines binding to these chemokine receptors, we looked in vivo where there was a relationship of expression of these chemokine receptors to how much integrated virus there was. And so this again was done in that same cohort where we looked at the frequency of central memory T cells that express CCR6 and CXCR3, and do see quite a nice correlation with how much integrated HIV persists in a patient. We went on now to perform leukapheresis in these individuals and isolate those particular subsets or cells that express both of the chemokine receptors of interest or don't express the chemokine receptors of interest, and again show there is enrichment in these central memory T cells that also co-express CCR6 and CXCR3. The question is whether this may possibly explain the enrichment of latency in rectal tissue, because rectal tissue tends to have very high levels of CCR6 positive cells, and those studies are ongoing at the moment together with UCSF. So just in summary, this model of HIV latency following chemokine exposure allows us to understand the early events of viral entry into resting T cells, but also a really nice tool to look at interventions that block the establishment or potentially reverse latency. We've shown that latently infected cells are significantly enriched in rectal tissue and lymph node compared to blood. They're mainly in these CXCR3 positive and CCR6 positive T cells. This also defines Th1, Th17 cells. And maybe one strategy to stop ongoing infection of resting T cell is to block trafficking to sites such as rectal tissue that are enriched with chemokines that will activate these chemokine receptors. But the problem really is that very soon after infection, you get your reservoir or your latently infected T cells are established very soon after infection. So all the action is kind of over once someone fronts up for treatment. So a far bigger focus has been made on what can you do with once a latency is established, how can you eliminate latently infected cells? And there's basically a number of approaches that people are using. The first is to treat really early. That's really preventing latency becoming established, a bit like what we saw with the Mississippi baby. And certainly if you can catch people very soon after infection and treat very soon after infection, you can profoundly reduce the number of latently infected T cells. Some really lovely studies done in monkey models, in fact just published in Nature a couple of months ago, showing that this really will reduce the amount of latently infected T cells if you can treat early. But it's very, very difficult to do that in reality, to catch people shortly after they're infected. Most people get treated several years after they've been infected because they're unaware of the time of infection. Allogeneic stem cell transplantation is another way that clearly eliminated latently infected cells. It did it in the Berlin patient, it did it in the Boston patients. We don't yet know how. The going theory is that it's through graft versus host disease or graft versus reservoir disease eliminates these long-lived latently infected cells. Boosting HIV-specific immunity might be important, although therapeutic vaccines have never worked very well in HIV, meaning someone with HIV on treatment can boost their HIV-specific immunity with a vaccine and stop antiretroviral therapy has never worked in the past. But there's indirect evidence to say that this could be important. And the other approach is what we call activating latent infection, a bit counterintuitive because we treat people by suppressing all the replication we can, and then this approach is activating latent infection. And this is an area that we've worked on a lot, and I'm going to explain a bit about the rationale behind it and some of the studies that we've done looking to see whether this works or not. So you're essentially, you've got integrated virus in 1 in a million cells, it's silent, it's not undergoing transcription, it's not expressing virions unless there's intermittent release. Can you actually activate and reverse a latently infected cell? And the idea here is a schematic of a latently infected cell, resting T cell, integrated provirus, completely silent, not expressing viral RNA or viral proteins, to activate expression of the virus, allowing for transcription, and we can measure this very easily, cell-associated HIV RNA in both the nucleus and the cytoplasm. The aim here is that this would eventually produce HIV proteins and package and release HIV virions. And the initial thinking was that if you could do this without causing broad-spread T-cell activation, this could lead to induction of death of the cell, because we know from loads and loads, years and years of work, that when a virus exits a cell, it destroys the cell that was infected by disrupting the cell membrane. You could also perhaps induce death of this latently infected cell, because just by increasing expression of HIV proteins, you would now get recognition from an HIV-specific CD4 or CD8 T cell, which we know are very frequent in people treated for HIV. So this approach is often referred to as shock and kill. So shocking the latently infected cell and somehow killing either through virus exit or another intervention. And there really are many, many compounds that can do this, at least in vitro. If you use various different in vitro models, you can activate HIV expression, may or may not cause cell death. And there's a whole host of drugs that do it. Clearly, drugs that alter epigenetic control are able to do this quite successfully, because an integrated HIV provirus with its promoter is exactly like any other host genes and is subject to acetylation and methylation. So histone deacetylase inhibitors will promote virus transcription, methylation inhibitors, histone methyltransferase inhibitors, BET domain inhibitors. Many of the drugs that are being developed, I'm sure many of you are very familiar about, that cause epigenetic modification, acetylation or inhibition of methylation, will drive HIV expression as it does all other host proteins. Then there are other groups of compounds where the mechanism is less well defined but have been picked up on drug screening. So cytokines like IL-7 can promote virus expression, disulfiram through activation of AKT, and then some compounds that the mechanism remains unknown. So we've got lots of compounds that seem to work in vitro, and some of these have now been moved into clinical trials, and the most attractive ones to move into clinical trials are the drugs that are already licensed for other disease conditions such as HDAC inhibitors, IL-7 or disulfiram. Finding latency reversing agents is an area of intense scrutiny at the moment. Can we get or access or identify compounds that do this effectively? And the big question is how you do this. I mean, are you best to take resting CD4 T cells from an HIV-infected patient on ART, stimulate ex vivo and then look at viral release? This is sort of the gold standard way of doing this, but it's difficult, as I started saying at the beginning. You often need leukapheresis. The frequency of latently infected cells is low. There is also quite variable responses because of interpatient variability. The other approach people use is latently infected primary T cells, like the model that I explained we had developed using chemokines, or dendritic cells, but the chemokine model is more is a better model for high throughput work. You know, this is resting T cells, and that you can get high frequency of latency in vitro, and there's different models either of pre or post activation latency. And finally, there are latently infected cell lines, which are by far and away the easiest systems to use, but they're not ideal. And they're not ideal because in latently infected cell lines, these cell lines are constantly dividing, which is not happening in vivo. These are resting CD4 T cells. These are generally clonal, and we know that HIV integrates in randomly, not a clonal integration site. So therefore, you will get differences in how transcription is controlled based on where it integrates. And in these latently infected cell lines, it generally integrates in heterochromatin, while in vivo, virus integrates into actively transcribing genes. So this is an area of sort of hot research because it's a tool that we need to identify new drugs. And we recently participated in a multi-centre study which compared a whole range of different models of latency and to a whole range of different activating compounds. And those compounds were blinded and prepared in one laboratory and compared to the sort of really hard work of patient-derived cells, often called a QVA, or a quantitative viral outgrowth assay. And this just shows you the different drugs that we have that activate latent infection. So you can fully activate the T cell and you almost always get virus out. You can PKC agonists will activate virus expression. A range of cytokines do. A range of HDAC inhibitors do. And then some other drugs such as ionomycin and HMBA. And the details of this checkerboard are not of that interest. The colour wedge just shows you the amount of the potency of that activation stimulus in driving HIV expression. And I think what you can really see here is a diversity of response and a very different response depending on which model you're using, and not all the models parallel to what we were seeing in patient-derived cells. So this isn't, as I've said earlier, really an area of intense scrutiny to try and get a good model that allows high-throughput screening. I don't think we have one yet, and at the moment the approach is many companies use cell lines for the initial screening and then will test their compounds in primary models and then, if possible, in patient-derived cells. Though interestingly, when a hierarchical analysis was done on the different models represented by different columns and the stimulus represented by different rows, you could see that the clustering of some models, including our own model of chemokine-induced latency, clustered very closely with QVOA, or patient-derived cells. So our model is actually now used quite frequently by many companies, at least, to identify new drugs that could reverse latency. So this is all in vitro, and what happens when you put the drugs into people and try and reverse latency? And the first drugs, class of compounds that have gone into clinical trials have been histone deacetylase inhibitors. And I'm sure there's many people in the room that know lots about these drugs and probably lots more than I know. But the principle of a histone deacetylase inhibitor is basically to inhibit histone deacetylases to cause histone acetylation. And just as that they do that in any gene, in any promoter, they will do that in HIV. So it's a schematic of what the HIV integrated virus looks like in a latently infected cell where you've got very little or no transcription and deacetylated histones, compared to what you have in a productively infected cell where there's acetylated histones and access of the appropriate transcription factors to drive virus production. And from all of the work that's been done in vitro, we know that HDAC inhibitors will move a sort of closed chromatin, deacetylated structure for HIV into a setting of virus production. So vorinostat was the first HDAC inhibitor licensed for the treatment initially of cutaneous T-cell lymphoma, and we had the opportunity of studying vorinostat in HIV-infected patients on treatment. Just to remind you that all of these studies of latency activation are always done in patients that are on treatment. It would not make sense to do that off treatment. On treatment, virus is well suppressed, viral replication is well suppressed, long-lived latently infected cells, and the idea is to activate the virus, integrated provirus, but not to have subsequent rounds of viral replication. So this is always done in the setting of people on long-term antiretroviral therapy who are doing pretty well, high CD4 counts, undetectable virus. And we gave, this was a single-site, single-arm, a non-randomised observational study. Patients received 14 days of vorinostat, a HDAC inhibitor that's probably one of the least potent HDAC inhibitors, but was the first and only licensed HDAC inhibitor at the time we started this study. And actually the study was just published earlier this week. And we measured unspliced RNA, so cell-associated RNA, to ask the question, can you actually activate transcription in vivo? And this just shows you the fold change of cell-associated RNA after giving vorinostat, the maximum fold change in the solid bar and the fold change out to day 84, several months after stopping vorinostat. And these are the 20 patients, and you can really see, I showed the individual data first because you can see that there's quite variable response. In some patients, you have very high activation of transcription, an increase of cell-associated RNA up into about 30-fold, and in some individuals, no response at all. But overall, about a 7-fold increase in unspliced RNA, which was really quite exciting because most people had always thought that latency was an irreversible state once virus became integrated into a resting cell. We looked, though, was there any virus released into plasma, and we saw no change in plasma HIV RNA. And did any of the cells die? And we measured that by HIV DNA, which is a measure of the number of infected cells, and there was no change in HIV DNA. This may have been because we only gave 14 days of drug. It might have been because there wasn't enough stimulus to actually drive virus production. You just got what could be just read-through transcription and not generation of viral particles. It could be that we don't have the tools that are sensitive enough to measure any change in plasma HIV RNA. We were interested in also another way that we could measure whether we got any protein was to look if we changed any of the, whether we boosted any antigen-specific T cells. So we measured HIV-specific T cells or response of CD8 T cells to GAG protein, one of the HIV proteins. We were actually quite interested in this because there's quite a lot of data showing that vorinostat or HDAC inhibitors suppress T-cell receptor function. So there's some concern that you might reduce any HIV-specific T-cell activity. We didn't actually see any change over the time of study, during study, 14 days of drug or after drug was finished. And we actually, if anything, saw an increase in the response to SEB. So we saw no evidence of reduction of TCR function. We did, in fact, see an increase in Tregs at the time on HDAC inhibitors. This has been reported before, but we didn't see any measurable suppression of HIV-specific T cells. But I think one of the key factors about this approach is that latently infected cells are really rare, 1 in a million cells, and we're using a drug that is not HIV-specific. It's going to have activity on a whole range of genes in addition to HIV. And so we actually wanted to interrogate this in greater detail. And actually, this has never been done in the same way, at least in the oncology literature. So we performed gene array studies on 9 of our patients. We collect blood at baseline, shown here in green, and we at very frequent intervals after receiving the drug, and this is just at 2 hours after receiving after receiving the first dose of vorinostat. And a gene array with, as you know, each gene a different row, red genes upregulated, blue boxes downregulated. You can see very clear clustering within 2 hours of a significant number of genes that are up and downregulated host genes. And they, as you'd expect, include a whole range of transcriptional co-activators and histone acetyltransferases, evidence of ER stress and DNA damage and chromatin remodelling, which is what we expected to find. We asked whether we could identify any gene signature of patients that had a really good response to the drug, meaning they produced lots of cell-associated HIV RNA, and here these patients are coded based on whether they produced high levels of unspliced RNA, so a good response to the drug, or low-level response of RNA. And we could quite clearly see clustering or a gene profile of individuals that had a good or effective response to the drug. And we're at the moment really trying to understand what some of these pathways might mean. You know, we do know that PI3K and AKT are very important for activating HIV transcription, mTOR as well. So this is an attempt to understand, couldn't we find a way to predict who is going to have the best response to the drug? But most importantly, when we looked out to day 84, so this was now 2 months after stopping vorinostat, we could see persistent changes out to day 84. The gene profile was different. There wasn't as much change in genes associated with chromatin remodelling, but clearly the gene changes are long-lived, and that can have some significant safety issues, especially in patients that we're treating here. These patients are patients doing very well on one drug, 1 tablet a day. These are very different patients who have cutaneous T-cell lymphoma, who have a very reduced life expectancy. So this has raised some concern about the safety of some of these studies, particularly with drugs like HDAC inhibitors. And we're currently at 2 years following these patients, and we'll get a sense of whether these changes are long-lived or not. So just quickly, in summary, HDAC inhibitors clearly activate HIV transcription and virus production in vitro in some but not all models. In vivo, we showed it was a modest activator of HIV transcription. We couldn't see any evidence of virus production or cell death. The increase in Treg function may be important, but we were unable to demonstrate any decline in a GAG-specific response. And the multiple off-target effects really raises some questions and concerns around long-term safety of these drugs. So can we do better, and are there any alternatives to vorinostat? Well, there's now been 3 studies of vorinostat in the setting of HIV, a single-dose study, an intermittent dosing, or our work on continuous dosing. But there are much better HDAC and much more potent HDAC inhibitors around. They include panabinostat, not yet licensed, but in phase 3 development. Romidepsin, which is now licensed. It's attractive because it's a class 1 HDAC inhibitor. It doesn't act on every HDACs. And that's been trialled. And then there's many HDAC inhibitors in development, and we've been quite interested in entinostat. Just very quickly, we were involved in the study of panabinostat, which was done in Denmark, published in Lancet HIV about a month ago, and we measured, panabinostat was given as 4 treatment doses with a week on, week off, which is standard dosing. And with panabinostat, again, we saw this increase in cell-associated RNA, so it activated transcription. There was some evidence that there was an increase in HIV RNA, but no change in HIV DNA. And then more recently, a study of romidepsin, the most potent currently available HDAC inhibitor. This was a small study of 3 doses of romidepsin, and what was special and encouraging about this study was that this is a measure of HIV RNA in plasma, and after each dose you can clearly see there was an increase in HIV RNA in plasma. So there has been some concerns that HDAC inhibitors just are not producing virus, they're just enhancing read-through transcription, but this clearly showed there was viral release in plasma, and again, no change in HIV DNA. So what what people are beginning to find is that you might get much more potent activation using a combination of drugs rather than single agents. And this work is not work that we've done, but it shows the different HDAC inhibitors I've shown you in clinical trials. We're back into ex vivo studies now, looking at how effective these drugs are in promoting virus production compared to when you fully activate a T cell with PMA and ionomycin. And you can see that the proportion of cells that produce virus is tiny compared to what you can get when you fully activate the T cell. And this is the HDAC effects of the HDAC inhibitors I discussed, vorinostat, romidepsin and panobinostat. When you actually combine these drugs with the drug bryostatin, a PKC agonist, you can get much more and significant activation. And this might be the way that clinical trials will be going next, although again, the significant concern here is around safety and toxicity. But probably the most important question that's come up now is that we have clearly shown that you can activate latent infection, you can produce cell-associated RNA, you can produce virions in plasma, but no one has yet shown that these cells die or you can eliminate those cells. And the question is whether you need to come in with another intervention which kills the cell. This could be through a therapeutic vaccine because you have now increasing antigen presentation in that cell, or it could be through immunomodulators such as anti-PD-1 or anti-PD-L1. And there really have been some very dramatic advances in HIV vaccines recently, using CMV as a vector, defining neutralising antibodies, and at least in mouse models, a combination of activation and neutralising antibodies did really prolong remission in these mouse models. And some of these studies are now moving into the clinic. The other possible good approach could be using anti-PD-1, anti-PD-L1. I'm sure you all are very familiar with PD-1 being expressed on exhausted T cells, highly expressed in the setting of chronic HIV infection as it is in cancer, and interfering between PD-1 binding to PD-L1 can reinvigorate the T cell, clearly shown to work nicely in cancer, and could be quite a good approach in the setting of HIV to reinvigorate or boost HIV-specific CTLs. And that work's been looked at in macaques. I won't go through that now, but it looks quite promising that if you give a macaque, an SIV-infected macaque, anti-treatment and then anti-PD-L1 and then stop treatment, a group of macaques will control their virus. And there currently is a study in the US looking at a single infusion of anti-PD-L1 in HIV-infected patients on antiretroviral therapy. Finally, just some current and future challenges for HIV cure research. I think one of the biggest challenges is what I call the hope and hype. It's really, and I'm sure many of you will face this in your own diseases of interest. Everyone wants a cure. It sounds very sexy, and anytime something's talked about this in the press, often the press misrepresents how close we are. There's certainly, I hope I've been able to convey to you the complexity in trying to eliminate these long-lived infected cells. So I'm not sure, we're certainly not within months, maybe not years, but hopefully at some stage. And finally, we actually surveyed our patients to ask them what they want from these cure studies, what's really important to patients. And we asked, what would you rank as the most important thing if you were cured? You know, not passing the virus on to others, not getting HIV a second time, being considered as a person not infected with HIV, stopping your drugs, not seeing a doctor, because this is really what we're trying to achieve here. And at least in Australia, where drugs are free and healthcare is free, you know, people really rank this as the most important, not wanting to pass virus on to others or being infected as HIV, or being viewed as a person infected with HIV, which I think the current strategies won't address. Stopping medications, not seeing a doctor, less important, but probably hugely important in low-income countries. So just finally, I've shown you this model of latency we've developed that we're using to screen compounds to reverse latent infection in vivo. It looks good because it closely parallels what you see with patient-derived cells. Histone deacetylase inhibitors can activate latent infection and induce virus production, but don't currently eliminate latent infected cells in vivo. almost certainly you're going to need something else that boosts immune control or clearance. And I think something that's very relevant for many of us that work in the field is that 80% of people with HIV live in low-income countries, and ultimately we're looking for a strategy that's cheap and scalable. So I just want to acknowledge many of the people in my group and collaborators. Fiona Whiteman and Ajantha Solomon did all the virology and immunology for the Verinostat study. Julian Elliott at the Alfred led that clinical study. We worked in close contact with investigators from Peter Mac, who are very experienced with these HDAC inhibitors in the setting of cancer. The gene array work was done with Rafiq Sekali at VGTI, Florida. The study was funded by Merck. Verinostat's a Merck drug. And some of the in vivo clinical work we do in collaboration with UCSF, and funding from NHMRC, NIH, AMFAR and Merck, and happy to take any questions. Thank you.
Virus production per cell during an acute infection with that what you can achieve with the HDAC inhibitors. I could imagine that there's several, at least one several orders of events where the death of that particular cell from that little expression that you get with the HDAC inhibitors may just not, may not actually register or affect the cell itself.
Absolutely. Talking about quantum, in untreated acute infection, you're producing 1 billion particles a day. We know that. So and and there's a huge amount of activated T cells. So that's in untreated infection. In treated infection, we're looking at these tiny, infrequent cells and the amount of virus. In fact, we actually can't measure the number of cells we're activating because these are all PCR-based assays. So it could be a lot of virus coming from one latently infected cell that's very easily activated, or it could be very low amounts of virus coming from many cells. We're getting better tools at that, so you've now got some nice fluorescent probes that can quite sensitively label cell-associated HIV RNA, but we actually don't even know whether it's coming from one cell or many cells.
You mentioned the non-specificity of the HDACs, and you said that you had an increase of HIV RNA. In that sort of study, did you look at other latent viruses that might be activated, like CMV?
We did actually, yeah. So HDACs, acetylation controls transcription of a range of DNA and RNA viruses. So CMV, EBV, HBV are all subject to control by acetylation. We excluded people with HBV. We measured CMV and EBV, saw no change. And we're currently looking at other endogenous retroviruses because it's quite likely that a range of HERVs or human endogenous retroviruses are also changed with the HDAC inhibitors, so we don't know the answer to that.
In latently infected CD4 T cell, can disrupting the gene insertion by, say, gene editing technique or something could be an option for treatment? Say like CRISPR-Cas9 technology.
Yes, I didn't talk about that approach at all. There's a lot of work on gene therapy in this field. Most of the work has been looking at disrupting CCR5. So you can using zinc finger nucleases, you can very effectively disrupt CCR5 and then basically make all cells resistant to infection with HIV. The other approach is to target the HIV itself and chop it out using CRISPRs or TALENs or other approaches. You can do that in vitro. There hasn't been anything that's moved into clinical trial. One of the problems with that approach is the diversity of HIV sequence. So the HIV sequence, I didn't talk about this, but when you've got untreated infections and billions of particles produced a day, there's a lot of sequence diversity, so it makes it a little hard using that approach in vivo. And some of the in vitro work shows that you can actually get escape once you start trying to use gene editing. But I think that could be a promising approach. The approach of targeting a host gene to make the cell resistant to HIV is far more advanced, and that's already in clinical trials and looks at least safe.
Do you see HIV activation or reactivation concomitant with other infections that are acquired?
Yeah, you do. I mean, I think a lot of that work was originally done in people off treatment. So we knew, for example, vaccination. If you vaccinate someone, you boost HIV production because you boost the number of activated T cells. And so generally, we don't vaccinate people until they're on treatment. But actually, there's more data coming out that if you, even vaccinating on treatment and using these very sensitive tools, I mean, all the stuff I was showing to you, you can't measure with the sort of assays that we use to treat patients. But that we use for patient care, if you use those sensitive tools, you can actually see changes in the cell-associated RNA just with vaccination. Yeah.
Does that mean there's room for an adjuvant approach, maybe with an HDAC inhibitor or some of the therapy?
Yeah. Might be, and I think some groups are looking at that.
I might ask the last question. In your patients that you treated with vorinostat, did you have the opportunity of going back to see whether those transcripts were read-through or they were LTR-driven transcripts?
We haven't. You can distinguish them by different assays, basically because of how HIV transcription works. It starts halfway through the promoter and then comes back and corrects it. So we're actually just developing the assays now. We haven't looked at it specifically.
One more question, if there is, otherwise.
One very quick question, thank you. Do you get an idea of the heterogeneity of activation of latent infection, either with your models or in vivo? So, for example, get an idea of that, what proportion, or measures the proportions of which remain latent versus the proportion which actually get reactivated?
Yeah, we don't. We don't because we haven't had good enough tools to do it. So as I was saying, just with PCR you can't tell, but now with we're using RNA flow, and you could actually use fluorescent probes that may or may not be sensitive enough. You might be able to answer that question. I think in vitro the evidence is that there is probably quite a bit of heterogeneity, depending probably on where the virus integrates, because perhaps in some parts of the genome it's very heavily silenced and you may not need to worry about it. And in other parts of the genome it's more likely to be released. So that's an area that is not well understood, but I suspect will be important.
Please join with me in thanking Sharon. Potential API getter.